one of the things I would say that I sometimes forget to say to people, and maybe in your conversation with families or with patients might come up. There's a sense for the general public that signing the power of attorney is giving away power. That once I sign this healthcare power of attorney or finances power of attorney, I've given away my right to choose or to decide. And I try to remember to stress that's not the case at all. You continue to keep your ability to make healthcare decisions and financial decisions as long as you're able to. The analogy I use sometimes is signing one of these documents. It's similar to giving someone that you trust the keys to your house. So it's, like sometimes you give your neighbor or your friend an extra key to your house just in case. So still your house, still have access to it, it's still yours, but you've given a key to somebody else who can help you if needed. You're traveling and away from your home or something happens to you, then the person can access to your house and help you in that way. So I just stress that because I think it comes up a lot, and I think it makes people afraid to sign these documents because they feel like they're giving away power. The other thing I want to mention specifically, because this is going to come up when we talk about healthcare directives, is that a power of attorney document doesn't give the agent the ability to admit somebody to a healthcare facility against their will. Basically, it's not the right language, but basically they can't agree, the agent can't agree to admission to a facility if the principal is saying no, they don't want to go. Likewise, mental health type, there are specific psychiatric treatments that an agent and a power of attorney cannot agree to, ECT and some others, psychosurgery and those things. An agent is not allowed under the law. Even if the power of attorney were to say they could, it's illegal for them to do so under a power of attorney. I just quickly want to mention the forms I'm showing you, the powers of attorney, have been translated into a few different languages. So if you're working with somebody who has English as a second language, it might be a good tool for working with them so that they understand the document and understand what they're signing. And then in the list of documents, so power of attorney for finances, power of attorney for healthcare, and then healthcare directive, also called a living will in some places, and as I've seen, most hospitals have their own healthcare directive. So kind of a few different ways to do it. Traditional healthcare directives, and probably the ones that are created from hospitals, deal specifically with a terminal condition or a permanent unconscious condition. And it goes through the list of things you do or don't want if you're terminally ill or in a permanent unconscious state. And so, you've seen this before, the artificial nutrition. Do you want CPR? Do you want a respirator? So that's kind of your traditional healthcare directive. They're straight to the point and deal with these two specific situations, terminal illness and permanent unconscious condition. The healthcare directive that we have available and created, it's about 5 pages. So that means it's a little bit longer and contains decisions that are a little more broad than that. So yes, we have the specific end of life care decisions, but also some other things about the kind of care that you would like to receive, what's important to you, where you would like to receive care if possible, what your hopes are for care, all of this around trying to help folks communicate when they aren't able to. And so it's been really interesting putting adding this language to the healthcare directive, and then seeing sort of what comes back from clients. So there are a variety of things. I love looking at what's important to people. So, they want to have their favorite pet around them when, towards the end of life, or they have a specific blanket that they love, or they really like peanut M&Ms, or, all these things that folks can put into this document beyond the sort of like nuts and bolts. This is the kind of, emergency care I want, but these are the things that are important to me and important to my life. So it's just, again, it's an option for families and folks to not only communicate, but also have these conversations before they get to the point where they would have to rely on this healthcare directive. And then I mentioned that the power of attorney for healthcare, or that an agent under a power of attorney doesn't have the authority to agree to admission to a psychiatric facility or long-term care facility, and doesn't have the authority to approve of certain types of psychiatric treatments. That's where a mental health care advance directive comes in. So the mental health care advance directive is specifically for folks who have a mental health disability and would like to create a directive that would advise their trusted people on the kind of care that they would need in a point when they don't have the ability to make decisions for themselves. So I think the example I usually use is somebody with bipolar disorder who has periods of stability, and then they might decompensate and not be in a place where they can make decisions for themselves. They wouldn't necessarily have the capacity to be making medical decisions. This document they can complete during a time of stability to talk about what kind of medication works for them, what kinds of other treatments might work, where they want to be. And then it also includes a statement about agreeing to admission to a facility if needed, and also approving different kinds of psychiatric treatment. So if somebody does want their agent to have the power to make these kinds of decisions for them, that's something they can do in the mental health care advance directive. I'm sorry, I'm just going to take a quick break. I know I'm kind of zipping through, but does anybody have questions at the moment?
There is a question in the chat from Karen Thompson, who wonders whether this also addresses end-of-life decisions.
The mental health care advance directive, is that your understanding?
Karen, you
Yes, I'm curious about the death with dignity and how that relates to people with decreased mental capacity.
Yeah, so let me think about, so the death with dignity laws, we don't have an advance directive for it because under the law, I'm sorry, I'm gonna have to remind myself, it's very specific about what your diagnosis must be. I think it's terminal illness, and the expectation of the end of life is within 6 months. And anyone who knows this better than me can check in. So it would have to be that very specific situation. And then on top of that, there's sort of a set number of times, providers you have to consult with and who have to approve. So yeah, it's 2, right?
I can speak to that if you just real quickly.
Yeah, you do it.
Yeah, so Carrie Rubenstein over at Swedish, I'm a geriatrician there. Yeah, so 2 things. You're absolutely right. So you need 2 providers to say a prognosis of 6 months or less, and you absolutely need to have decision-making capacity to make this life-ending decision. So therefore, not all of people living with dementia, but many people living with dementia will be determined not to have the capacity. And you can't write that into the mental health advance directive to make it active when you lose that capacity. So that's absolutely right.
Yeah, thank you. Thanks so much, Carrie. I really appreciate that. Yeah, so it is true. I mean, that's the difficulty, is that folks with dementia, probably by the time, the terminal within 6 months, they've lost the decisional capacity. So there are some really limited situations where someone has kind of both, but it really falls in this specific line. And I know that there are folks looking into the possibility of, for instance, a VSAID, voluntary stopping eating and drinking directive. So that's something folks are researching right now, whether that's an option. I know it can be controversial, but that's just to throw it out there for something to look for in the future. I know that there are folks both in the legal and medical fields researching whether a visa directive is a possibility.
And Meredith, Sylvia Russo was asking what advice you have about patients who come to medical care with more advanced dementia who don't have capacity to help family manage their finances, and what kind of documentation needs to happen for the family to have the ability to access their finances and help them out.
Great. Yeah, that's a great question. And I'm going to cover that in just a few minutes. Yeah. Anything else, Allison, question-wise?
No, timer-wise, though, about maybe another 13 minutes or so.
Okay, perfect. Yeah, we can zip through. So mental health advanced directive. And then I'm going to talk about 2 dementia directives. So there's the first I want to talk about is the Living with Dementia Mental Health Advanced Directive. And just a note about the name, I know it's weird. The reason they have the term mental health in this directive, even though it doesn't make sense, is to pull in that part of the statute that says the decision maker can admit somebody to a facility, they can approve certain types of procedures. So that's why that term mental health is in there, even though I'm sure, like, I know it drives me a little crazy, I'm sure as medical providers, it makes you a little nuts too. But in any case, there's a legal reason for it. This is a hefty document. It's big. It deals not just with medical care, but like social, personal care. So there's stuff about the medical, but there's also stuff about life. So what point do I want you to take away my driver's license and prevent me from driving? If I go to a facility and I start up a romantic relationship with somebody, is that okay with me and with my husband or wife or whoever? I mean, these kind of thorny issues that people may not understand they need to think about before it starts, or before they're there. And also to let their family know what it is that they want. So it's a commitment to fill out this document, but it also, again, provides that opportunity to sit down with your family and talk with them or your caregivers and set out expectations ahead of time. And then there's also the dementia directive. I'm sure you're familiar with. Dr. Gaster created this. It's really popular, and it's really well structured in terms of walking through the stages of dementia. And so it's a more, I was going to say more accessible. That's not. It's a shorter document. So our goal here is to get people to complete these because it really does help them. It helps their medical provider. It helps their families. It's a really accessible document in terms of, again, kind of walking people through the stages and understanding what to expect, hopefully, and then try to make decisions based on that. Just quickly, these documents, powers of attorney, healthcare directives, should be notarized. Give copies to your agent, keep a copy with important papers, make sure your medical provider has copies. There is option for folks to, if you can't get a notary, this happens a lot in the hospital, but they can be witnessed by 2 people, but there are restrictions on who can be witnesses. So they can't be, for instance, medical care providers at the hospital or facility where they're receiving treatment. So just to let y'all know. I don't want to spend too much time. This is obviously not a legal document. This is Portable Orders for Life-Sustaining Treatment is a medical document. But I do get a lot of questions about why should I have a POLST and a healthcare directive. And so certainly the explanation is that in emergency services providers will not abide by your healthcare. I don't know if that's the best way to say it, but won't abide by your healthcare directive that you've prepared. So, but a POLST is a medical order, and they will follow the POLST form. So if you, for instance, really just don't want CPR, it's a great idea to have a POLST, because if you have a heart attack in your home or wherever, they're going to administer CPR. The emergency folks will. And then the question about what if someone doesn't have capacity, what are the options? As I mentioned, the finances is a really hard one, and it may require conservatorship. So I'll deal first with healthcare. There is at least the consent to healthcare statute. You all are probably pretty familiar with this. It's a hierarchy of folks who can make medical decisions for you. So obviously a guardian, power of attorney, great. If you have those folks are making the decisions. If not, then it walks down the hierarchy, you know, a spouse, children, parents, siblings, grandchildren, aunts and nieces. The healthcare provider can't skip a level. If there are adult children, they can't then get permission from the parents, or I'm sorry, consent from the parents. So they do need to follow the hierarchy. And in addition, the complication with this, and you all probably have stories, are that everyone within a level has to agree. So if you're talking with the adult children of somebody who needs healthcare, all the children have to agree, and in order for the decision to be made. And then I mentioned guardianship. Our laws changed recently, as you probably know, but we've added some more terms. So it used to just be guardianship of the person, guardianship of the state. Now, after we adopted the Uniform Guardianship Act, Guardianship, Conservator, and Protective Arrangements Act, the mouthful, guardian is the person who's going to be making healthcare decisions and personal decisions. Conservator is managing money. And then in addition, there's really a push to give people less restrictive alternatives to guardianship and conservatorship. So it might be that the court could enter what's called a protective arrangement, not a full guardianship, not a full conservatorship, but really specific to a particular decision or decisions that need to be made by an alternative person. And then I mentioned, I'll whip through the resources really quickly just so you have them, and then I'll make sure Allison has this PowerPoint. But if you're looking to refer folks for help completing their powers of attorney and healthcare directive, they don't have to have a lawyer, but if they want some help, there is the Dementia Legal Planning Program. It's statewide. It's specifically for folks who have a diagnosis of dementia, but I think they've opened it up. So, you know, concerns about dementia, history, you know, and then seniors, people over 60. I just think, you know, if you have a question about it, go ahead and refer them to the Dementia Legal Planning Program, or give them the phone number. Here it is. The nice thing about this, again, it's statewide, and also it's done virtually. So if somebody isn't able to go to a clinic or go to an office, it's an alternative. And then if you're in King County, Senior Rights Assistance also has a clinic for folks. They're doing powers of attorney, but they also do wills. So certainly have folks reach out to them if they're interested in getting help. These are the phone numbers for the Northwest Justice Project. If people have, like, not only, like I mentioned, we do a lot of civil legal services, so there's some other options if somebody comes to you with a problem that's maybe not advanced planning, but something else. And all the resources I mentioned today, we have on our website, the WashingtonLawHelp.org website, including links to some of the dementia directives that I mentioned. And we have a lot of other documents on Washington Law Help. So in addition to these forms that folks can fill out, these are some of the ones I refer to a lot. Like, I'm trying to remember what the COPES limits are, or the Medicaid for nursing home limits. Great resource. I go back to it all the time. It has, you know, concrete numbers in it. And then, of course, the Dementia Legal Planning Toolkit. Many of you on the call were instrumental in making this happen and contributing, editing to the Dementia Legal Planning Toolkit. It's got just really practical information for folks and families planning ahead for who have a dementia diagnosis or concerns about dementia. And then also, if you get the physical copy, it's got the forms, the powers of attorney and healthcare directives in the back. And then the Dementia Roadmap, also a really wonderful resource for families and excuse me, care providers that walks through sort of the stages and what to expect. And I mentioned the Dementia Directive, the website for Dr. Gaster's Dementia Directive, and the End of Life Washington Directive, and done. Yeah, I'm happy to answer questions, Allison, Chris.
Yeah, we have a
Yeah.
couple of minutes. We
Yeah.
certainly can take a few, and thank you. And also just a reminder too that Barak did a really nice 2-part advanced care planning echo didactic series that's on our website with some other information that complements this very nicely. So
Yeah.
questions or conversation from the community? Let's see, one thing in the chat, Carrie asking about a potential change to allow medical team members to be witnesses, but I'm not sure if that's the case.
I haven't heard that, and it's, so one of the things that's a little bit challenging, the rules slightly different for powers of attorney witnesses and healthcare directive witnesses, but both say, and I just checked the other day, that it can't be healthcare providers in the facility where you're currently receiving care. Yeah. So I haven't heard about a change, but I don't know, maybe somebody else has.
This is Carrie Rubin. So yeah, I think there was some change. I think you're right. It's super confusing because it's a little different but there was some change whereby I was told, I think for the durable power of attorney for healthcare forms, that like I as the physician could sign like, for my patient. But I can, maybe both of us can look that up and try to come back to the community because maybe I misinterpreted it. Great.
Yeah. No, that would be great. Yeah, I just wrote it down to see. I'll ask around or do a little bit of research and yeah.
Great, that'd be good to follow up on. And then it looks like Mackenzie has a question. Mackenzie, are you able to unmute and ask that, or do you want me to? No, Mike.
Oh,
no problem.
Mike.
And we can help with that. We've got some budget for technology. So let's see. Do the forms have to be state specific, or can they be modified versions to say whatever they want?
That's a great question. Yeah, they don't have to be state specific, so I don't want to get in the weeds too much, but we actually in Washington have adopted the Uniform Power of Attorney Act, and so which is accepted in a few different states, not all of them. So I think that's the idea with the Uniform Laws Committee, is that they'll come up with some of these uniform laws, like the ones we've adopted, like the power of attorney and guardianship, conservatorship, and that, would be other states will accept it as well. And then there'd be all this, friendly cooperation. All that to say is the forms that I put up are created with Washington law in mind. So I know that they're acceptable in Washington state. I don't know that they are in, other states. So I guess I would just say if you're dealing with somebody outside the state of Washington who needs to do a form to be used at a hospital or wherever outside of Washington, it's a good idea to check their laws in the other state. And then, if we get, it's my opinion, if we get a form from another state that does comply with Washington laws, it should be acceptable here as well. So I hope that helps or answers the question. If there's follow-up, feel free to chat.
Good, appreciate that. And Meredith, are you okay if people contact you after this? Okay, great, appreciate that.
Yeah, definitely. If you have other questions that y'all think about, my information is in the PowerPoint, and you're welcome to reach out. Email's usually easiest to get a hold of me. And I saw Mackenzie ask which ones have to be notarized. Financial power of attorney, healthcare the powers of attorney and healthcare directive shall be notarized.
Very good.
There is the alternative of witnesses, but if at all possible, get it notarized. It just will make things so much easier for your agent.
Wonderful. And thank you so much also for the focus on resources. I think it's one of the most helpful pieces of our didactics are the tangible things we can leave with to be able to better serve our patients and families. All right, and Meredith, you are more than welcome to stick around, but out of respect for time, we'll also understand if you need to move on to something else as we transition to our case.
Great, thank you all. Thanks so much.
Thank you so much for coming. All right, so let me reshare my screen here. And I see Brad is with us. And we took the liberty, Brad, of populating your case into some slides. So I'm happy to drive the slides if you want to kind of work through your case. And thank you for bringing this to our session today. It's lovely to see you again.
Okay, hopefully everyone can hear me all right.
Yep.
Awesome. Okay, so thanks for having me. I have been somewhat of a wayward traveler for a while now for a variety of circumstances, but glad to join you all today. This is a very unique case. Over the past few years, which it totally blew my mind when you said I first did this 3 years ago, I've kind of become the contact person, for better or worse, at our clinic for cognitive evaluations. And they've often started to follow a pretty set pattern, but this one broke the mold a little bit. And the PCP wanted me to bring this patient here specifically and just get some thoughts. Basically, you know, some background that may not show up on this slide deck, which I appreciate you guys putting together, is that I actually had seen this patient a few years ago for various concerns like knee pain, elbow pain, just in our same day clinic. So I can speak to the abruptness of the changes that we saw here. So that's definitely a piece of this, but let's just kind of go through the slides, and then I've got her chart here, which I'll, censor as needed if we have any other questions. So this was a 84-year-old lady who came in for one of our cognitive evaluations. She said she wasn't worried at all, but importantly, she didn't really say anything. So she can converse a bit, but no meaningful conversation at all. She kind of giggles everything off that you ask her. Her speech was very difficult to follow. And again, it didn't used to be that way at all. Her husband sat there a little bit shell-shocked, I would say. I did not know him before, so I don't know if he provided more history in the past. But basically, why is my wife losing her memory and what can we do about it? So let's see if there's anything else. Yeah, there was a UTI, but that didn't seem to be playing a role when I saw her. Let's go ahead and move to the next slide if that's okay. Okay, so yeah, mood was fine. She was agreeable and, as conversational as she could be. That was the other piece, was everything I tried to direct at her, she would just immediately kind of turn to her husband and giggle and hope that he would answer for her. We did not do slums testing. I don't think we could have done any meaningful questioning by the time I saw her at all. That's kind of that slide. Okay, and so this was my plan from that note, pretty much verbatim. So I did talk with PCP, who's one of our medical doctors here, and we did get that MRI done as a next step. I will pull that up on my end. I don't know if I've got all of the results there on the slide or not. So feel free to move ahead. There you go. Okay. So they said no acute intracranial abnormality. They said that she had some small vessel ischemic changes. This was the more interesting finding for us, was that there is neurodegenerative etiology that might be mesial temporal lobe focused. I will add that right after this MRI was done, the PCP, who knows this patient very well, saw her and said that she had done some research on corticobasal degeneration as a possible etiology, which was listed as a rare neurodegenerative disorder that poses significant challenges to diagnosis and treatment. So in our primary care world, we didn't really know what to do with that. They said that there was some, ventricle did not seem dilated, but that neurodegenerative finding was the main thing. Let's go ahead and change and see if there was anything else there. Okay, so this was prior to my evaluation. PCP had done some labs. Everything was normal. These are the labs we typically check for our cognitive evaluations. If people see any glaring missing labs there, would love to hear that. Kind of as a Hail Mary, as it often is, I said, well, let's try some Aricept and see if we can, have any impact there. PCP then saw her, moved it up to 10. It's not doing anything. she continues on as she has been. And so there's some potentially useful history. AFib, she takes apixaban for that. We got that on there. She does mirtazapine at night. Those are really the only significant medications I saw. She's got eye drops listed. She's got collagen supplements. She's got multivitamins. That's kind of the majority of her medicine. Let me quantify the weight loss for you. Let's see. So I hope I can pull that up here. We have a little different view. I'll just give you a spot check. So when she was seen in June of this year, they had her weight at 96 pounds, BMI of 15. I'll go back about a year ago and just see what a year's done. So last July. Here, I hope this is helpful. No, she's been stable for the past year, so she's low weight. I don't know exactly when that dropout started. I can usually pull up a graph, but I'm not able to on my after visit view. So let's, then, I put history of breast cancer. I've had people show up before with just very abrupt changes, and unfortunately it's been a recurrence of cancer. So we have not found any evidence of that. She's up to date on screenings. So I don't think that's any part of this right now. Let's go ahead. Yeah, so hopefully that's a good overview. I would love any guidance, because here we are in our rural primary care, just throwing Aricept at something we don't really understand very well. So thanks for listening, anyone who's stuck around, and I'm happy to answer questions if I can.
Yeah, no, Brad, thank you for bringing this great case. And I'm guessing we have a couple of folks in the audience who have some questions about the corticobasal degeneration piece as a possibility. I know I have a couple, but I'm wondering, before we launch into that, for our community here, what else would you want to know about this case? Knowing that it may not be knowable, but what would be important to think about here? Feel free to unmute or throw something in the chat if you don't have a microphone, or
Hi, this is Nicole. I was just going to mention, it seems like based on some of the information you gave and my interpretation that the husband may not be the best caregiver of his wife, just in terms of understanding what's happening with her. I guess I would question medication compliance all around. I remember you mentioning something about a UTI, and I wonder how that resolved, if there was question about her even taking an antibiotic reliably.
excellent question. And Brad, it sounds like you've done subsequent urinalysis that would confirm that the UTI has resolved.
I am looking, let's see, this would be, I'm sorry, everything's a little different after the visit. So, no, there has not been a repeat. Now she does, so she's also, I'm looking back into the last fall even, it does seem like there's repetitive urinary issues. I just know when I saw her this spring, that PCP said, had a UTI, no longer has one. I don't see any objective proof of that.
Trang, go ahead.
Oh, yes. She has an AFib, but she's not on a rate control. Was she on a rate control before? How's the blood pressure and heart rate?
Great question. I'm going to go back to vitals on the day I saw her. So the day I saw her, blood pressure was 102/62, pulse was 74. I can actually go into her PCP's overview. She does a great job of these. So she said in the past, she did do metoprolol 25 milligrams BID. There was at some point a catheter ablation. So that's 2015. They said repeat Zio 2015, no recurrent AFib. Cardiologist in 2021 said there was amiodarone in the past that worked, but they discontinued that. There's unclear when and why metoprolol was stopped based on the notes I have. So they just say she was on it for a long time and she's no longer on it. So amiodarone and metoprolol in the past, nothing right now.
Yeah, her blood pressure is low. You said 102?
Yeah.
102, yeah. And then the mirtazapine dose kind of high. So is it helping her, or maybe she's not taking it? Maybe she's not taking it.
I don't know. Sorry, I don't know if I would not know if it's helping her or not. I mean, when I say no usable history, I mean no usable history. So having gone a few years between seeing her, this was really abrupt for me. That was kind of my first question to her doctor was, has she been this way, or is this a real abrupt change? And I think we all see this as pretty abrupt, but I unfortunately couldn't tell you if she is sensing an effect from her medicine or not.
All good questions. Other questions or things you'd want to know about this case? I have one just as people are thinking. So Brad, it sounds like she doesn't have any other prior cognitive testing, nothing as part of a Medicare annual wellness visit, like a mini cog or a mini mental.
All right, I keep muting. The only mention on her chart is 7 months ago, which was when she was first told about CP. So no prior evidence on here of any memory issues.
Right, and no prior establishment of any kind of baseline either, like, oh, she's always had a 3 on the mini cog or.
Not to my knowledge.
Okay.
But just that alone, I can speak to as a big change. Just her ability to.
Other questions? Dr. Russo or Dr. Demoto-Riley, do you want to ask some questions about CBD?
What I would say is CBD or CBS, to be fair, is one of the most difficult diagnoses to make, even for neurologists. And sometimes there is classic CBS or cortical basal syndrome that may present like Alzheimer's or may present like Parkinson's. The classic cortical basal syndrome, per latest criteria, at least the motor variant, is an akinetic rigid syndrome, which is typically asymmetrical. What this means is the person typically presents with really hard time moving one side of the body. Typically, it affects one limb. And so the classical cases of cortical basal syndrome, you can typically see when you spend like 5 minutes with the patient. There will be one arm that will be fixed, really curled up. There can be dystonia, so really fixed position, really rigid, and there can be more complex phenomenon like we call alien limb syndrome, where the arm will just act out of its own way. There can be behavioral problems. And so I don't know how much of this was evident in the visit. And so that arm becomes useless in the most obvious and evident form. And so that's the syndrome that we think of classically as cortical basal syndrome. Now with the new guidelines that came out, I think not too long ago by Armstrong and all, it's in neurology, you have other forms of it too. So there is a language predominant form where the patient loses the whole kind of ability to speak fluently. And so it's called the non-fluent primary progressive aphasia form that may have some motor symptoms too, but typically language is more effective. There is a frontal executive type. And on MRI, more than just ventriculomegaly, which I think was the main evident finding. And again, this has been debated, but typically you find unilateral atrophy or predominant atrophy on one side of the brain. And the typical area, and again, we're talking about the typical syndrome, but corticobasal syndrome is like syphilis in my mind. It can present anyway. You can find that the atrophy is typically in the motor and sensory areas, which are the areas that are contralateral to the arm that's affected. So this is the simple corticobasal syndrome. And I don't know if, this seems really hard case to deal with, but during the period that you spent with her, you saw any sign of this?
I would say just memory, she definitely had some motor abnormalities, but it was more of a, I'm a primary care PA, so forgive me, but more of a chorea comes to mind. So more of just a general kind of dancey movement. She's 84, so I don't think Huntington's or anything, but definitely jerky. I don't remember the one area that had a deficit though, but we could totally recheck for that.
Yeah, and I may have missed this during the presentation, but is she on any antipsychotics or have been on antipsychotics?
So I don't believe she's on any right now other than, so mirtazapine is her only mood medication. I'll go to all of her old medicines here and just scroll through. Nothing that I can tell, nothing that I'm aware of. Lorazepam once in the ER. No.
That's very interesting. So the choreiform movements, it may be worth having her seen by a movement disorder specialist to kind of clarify the diagnosis, because chorea, you guys can correct me if I don't know this, but doesn't seem to be a classic presentation of corticobasal syndrome, at least from what I've seen and my limited experience with it. That seems more like it's either, extrapyramidal syndrome from chronic prior exposure to antipsychotics. There can be some autoimmune conditions that cause this, antiphospholipid syndrome. But again, being 84, it's hard to foresee that. And then going into the weeds, there can be rare late onset forms of Huntington's disease, which she may be the first proband if it presents so late, because she may have just a few triplet repetitions that may not allow you to see a family history yet. But those are the things that I think about if truly that's a chorea. But I don't know if Dr. Demoto-Riley has heard of this with corticobasal syndrome. It seems like unlikely from what I heard, but.
Yeah, Dr. Russo, you did a fabulous job of sort of presenting the simplest way of thinking about corticobasal syndrome. And I guess, and Brad, you were holding out on us on the motor symptoms. Certainly that adds a layer of complexity and maybe some important clues. And I think it is so hard to characterize these movements. So things to think about, and perhaps the next time you see her, is there also a component of stiffness? Stiffness to her face, stiffness to her movements. You could even see if, there's increased tone. And Dr. Russo has already asked about, was she exposed to medications which would cause Parkinsonism? In corticobasal syndrome, we can see myoclonus. Sometimes especially at the beginning, it's infrequent. And I will ask patients and families, like, it almost looks like if you stuck your finger in a socket and there's a sudden jerk, a big jerk. And it can also be of the trunk. And sometimes it's just hard to catch, but that would be a question of, maybe these, I mean, it sounds like you certainly saw abnormal movements, and maybe it was more myoclonus. But yeah, any other thoughts on her, her movements? And I guess another question would be, I know the husband was maybe just shell-shocked by everything, but thinking about her ADLs, and maybe there's a problem with her toileting, but I wonder about dressing, and because then there's the physical aspects of dressing, and I just wonder if there was any concerns about her basic ADLs.
I think that's probably a big issue for her. I don't know what their family situation is, so if they might have someone else at the house, but just two of them, I'm sure at this point he's probably doing a lot of that. Which, I mean, she came in very nicely dressed, as she always does, so I don't know if he's to thank for that. She wasn't unkempt or disheveled or anything like that, but I think it'd be challenging for her just based on the limited interaction I had with her that day.
Wondering what other recommendations, or if this was your patient, how might you pursue next steps? I want to agree with you, Brad, that I don't think any cognitive testing is going to be particularly revealing at this point.
Since the husband is having kind of a little bit of difficulty, from what I've heard, trying to kind of deal with this, I would just give them little homework, so to speak, just a little bit at a time. Say, for example, next time you come, I want you to relay on this. I want you to keep an eye on, and you decide the things that make the more sense and are the most safety involved. So medications, I want to make sure we know all the medications she's taking, have a pill box, understand, watch her first, understand, is she taking them? And if she doesn't, then we need to help. The pharmacy can do pill packs if they can afford them, etc. And I don't know about the bills and things like that. And as Dr. DeMoto Riley said, kind of basic activities, is she having trouble? Or can he relay on what does she do when she's getting dressed? Or does it take a long, long time even to get dressed? And this gives you an understanding of how functional the person is. And really, really knowing what medications she is actually taking makes a whole lot of a difference to understand, is it working? Is it not working? Is the dose appropriate? Is it not appropriate? Is there any side effect that we're observing from the medication itself? And so it all can be overwhelming from what at least I see to somebody who's not in the medical field, let alone to somebody who is in the medical field dealing with this. And so start with one piece of homework. Look at the medications. This seems like the very important first thing because it has safety repercussions. And then maybe the next time you focus on some other areas of function. And kind of what I try to always assess for is how stressed does the partner look in their day-to-day living with the patient, because they will try to hide it or they will try to not show it. He seems like he's showing it, that he seems overwhelmed. And so any case management or social worker that can kind of help them navigate this and help them kind of lead the way for them to understand, okay, how much help do you need? Do you even know how to do this? Do you even know what things we will be looking for in the future? That's definitely a partner to have moving forward if I were there.
Those are great recommendations. And Brad, I'm wondering too, does your clinic administer any kind of, questionnaires about IADLs or ADLs, like the Lott and Brody or the CATS or anything like that?
I'm not in the clinical part of our practice, but we do have a pretty robust annual wellness visit program. So I think they are checking off a lot of that stuff. I just don't know that she's had one recently. Says she's overdue So she had one last summer. So I could find that and kind of maybe use that as a reference to see where she was. That should have some of that.
Yeah, I'd be curious to give her husband a set of those too and see, sometimes it's easier to fill that out on a piece of paper than it is to talk about it even in front of somebody who's got some cognitive impairments, but something to think about.
I will say, I really appreciate everyone's feedback, and it's been an excellent case to hear from my standpoint. One question I know will be asked is what I already think we know the answer to. The abruptness of this onset doesn't signal any reversibility, correct?
You had me wondering about like an MCA stroke, maybe a small one with the expressive speech difficulties, but the MRI, isn't revealing for that.
Yeah, just that chronic small vessel changes on the MRI.
I also think about, I'm thinking about somebody I saw last week who is kind of a similar story of functioning pretty well with maybe some smoldering changes, but obscured by pretty good routines and not a lot of challenge, and then had a fall and a head injury. So not a UTI, but a fall and a head injury that seems to unmask or kind of tipped this latent process into full swing and just hasn't recovered back to baseline. But a question of like, is it a brain injury? Was there some other event that occurred? But really it seems like it was a smoldering process that got unmasked. And I don't know that that's the case here, but I don't know if others have thoughts about that, or
the question I would have is, does anybody else know this person? Does anybody else other than the husband know her?
I don't know. I mean, in our clinic, she has a long-term relationship with this doctor, very long-term. So she's my best point of reference. She looks like she's in very regularly, every 2 months or so, she's in with her doctor for at least the past many years. So at least those people do. I can see some of our old case manager nurses who have since retired, knew her well. So I think there's probably a clinic baseline of what she's like much greater than what I would know from our one.
Right. So really getting into the details of like, what was her movement at that time? What was the way that she would speak and present? Was she late, or did she ever get lost on the way to that appointment? And, being 80, people are kind of more inclined to think, oh, it's irreversible, or oh, it's just that she's old and she's more vulnerable. But, the clear things, the clear, obvious, and, clearly reversible things to always keep in mind are vitamin deficiencies, occult cancers, autoimmune conditions. If she's ever been, it would be rare for an autoimmune condition to present at 80, but not impossible. And within tying that up to that, paraneoplastic and autoimmune conditions of the brain, which with the movement disorder, have to be in the differential. Again, we're fishing for really, really rare stuff, but patient is allowed to have as many rare conditions as they want, So thinking of maybe with a neurologist as to even taking a video of these movements, taking a video of her speech, because a video sometimes gives you a whole lot more information than trying to describe it. And it's not just you, it's even neurologists sometimes don't know how to describe these movements, and they just take a video and show each other, And so I think that's the best way moving forward. And if really there is a concern for something that's clearly acute, wasn't there before, then go down the path of, are we ruling out an advanced cancer like a lung cancer that could be causing, a paraneoplastic syndrome? That would be things that, they're rare and they tend to take a lot of work, but it's still important to try. And the one thing that I will never cease to be amazed of, especially with these older people, is HIV. I just had one person who came with a quote unquote rapid progression of dementia and gait and dressing apraxia. And now they're being evaluated for possible HIV. And I've had another younger person that had this clearly rapid progression of dementia who had PML, progressive multifocal leukoencephalopathy, from HIV. And so it's probably been done as part of the routine medical studies, but if it hasn't been done, I would not rule it out automatically. I would actively rule those things out because I've been burned before and it seems stupid, but it happened to me. So.
That's a great point. I'm scrolling through and there's no HIV tests, probably because she's over 65. We've tried to get all of that preventative measure met in our clinic, but yeah, no HIV tests. So that would be very interesting.
Brad, I want to, yeah, Brad, I want to remind you too that one of the benefits of presenting a case is that you have unfettered access to Dr. Eisenberg and I in between sessions. So if you do take a video of her movements, if you see her, I'm sure Nancy would be happy to take a look at that. Similarly, if you were to record her speech, I would be happy to take a listen to it. I'm sure Nancy would too. The aphasias all present slightly differently. Gives you a little bit of an idea about some of the architecture that may be involved. Well, let's see, is there something in chat here? Oh, looks like Nicole had something in chat also. Good. Let's see. Nicole, you want to unmute and ask that question or?
Oh, sure. Thanks. I'm Nicole. I'm a social worker, and as a social worker, I can't help but think it would be kind of a nod to what Dr. Russo was saying. I think it'd be wonderful to connect this couple with some sort of services, ideally something that could come into their home. I think that could be very telling to just kind of get a sense of their environment and better look at how they might be managing meds, how ADLs and IADLs may be being met. And then making sure the husband knows what available resources are most suitable for them, both for, for the both of them really, for, making sure she's getting the care that she needs and also some respite and support for him. So I don't know if there's any indication that she might be eligible for home health, that would be a pretty easy resource to make sure that a social worker could get in the door in addition to any skilled services she might benefit from.
That's a great point. And you're reminding me, Nicole, too. Sometimes one of the things that we recommend for somebody who can't do any kind of cognitive testing, whether it's because of aphasia or just language or whatever it may be, is an in-home assessment with OT. And I don't know if that's an option, Brad, out there, but that could be a really nice kind of real world, highly ecologically valid assessment as well. And then Kimmy, your point of given the weight loss would have a very low threshold to screen for dysphagia. Excellent point. And we are at the 1:30 hour. If you have other thoughts, please feel free to throw them in the chat, or you can email me. I will send a compilation of these to you, Brad, in terms of all the things we talked about. Although I love seeing people take notes because you're more likely to remember it if you take a note. But so the last thing I will share with you is the survey link is in the chat. And Lynn has reminded us that the Dementia Action Collaborative is inviting you to review the updated state plan. It is the public comment period through July 31st. The link is there. And boy, what a process that has been, getting that over near the finish line. So, all right. Well, thank you all so much for joining. Thank you, Brad, for bringing this great case. And be interesting if you're up for it to get maybe an update in a few months, depending on what comes.
Yeah, I'd be happy to plan on that.
All right. All right. Well, with that, say goodbye to you all. Oh, our next session will be resources from the Alzheimer's Association from Erica Farrell, who is the Senior Clinical Manager at our local chapter. So that's Friday, July 28th, and we will see you then.